The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hello, everyone, and welcome back to the FlightBridgeED MDcast. My name's Mike Lauria. I'll be your host. I'm an emergency medicine, EMS, and critical care physician with a particular interest in critical care transport and working actively, actually, as a flight and transport physician. Welcome back to our series on OB critical care. Today, we have a topic that's very near and dear to my heart that is actually relatively common and I think is really important that we're going over: maternal sepsis and septic shock. As an introduction to this particular series, we're really focusing on trying to improve the care of critically ill moms, and specifically critically ill pregnant females as it relates to obstetrical critical care. We're kind of in a predicament in this country, and unfortunately it doesn't look like it's getting much better, because over the past 20 to 30 years, maternal mortality has risen significantly in this country, and now we're down to about 65th in the world. That's right behind Malaysia, and we're coming out just in front of Costa Rica and Iran in terms of our maternal mortality, and it's getting worse, and that's not good. Where our critical care transport comes in is that actually a lot of these places, as many of you know, are unable to offer peripartum care to very critically ill moms, and a lot of them are going to get transferred. In fact, about 37% of these facilities where actually a lot of these moms are initially seen, where these pregnant females are initially seen, have no critical care services or maternal fetal medicine or other specialists and have to get transferred. And remember, it's not just while they're pregnant, it's also taking care of critically ill patients after they've delivered, because a lot of these problems manifest after delivery. And so this entire series is focused on improving obstetrical critical care. Here to help me with this series, my curator and co-author is Dr. Elizabeth Garchar. She's an OBGYN and MFM. She also has the unique experience of being one of our retrieval physicians and flies with us at our flight program. Real quick, of course, Elizabeth and I have no conflicts of interest. We are going to be discussing some of the evidence, and we're going to be reviewing some of the science behind caring for septic obstetric patients or obstetric patients in septic shock. But always remember that what we are discussing today does not substitute for your local protocols, guidelines, regulations, or laws. So always stick to your local guidelines. Now, without further ado, let's talk about maternal sepsis and septic shock. So really, maternal sepsis is essentially sepsis or septic shock during pregnancy or in the early postpartum period. And remember that the infection itself is causing a very dysregulated immune response, specifically a cytokine release that results in terminal organ dysfunction. And I think it's really important to emphasize that it's not just the organ that's infected, it's this systemic response. And we see this all the time in the emergency department and the ICU, and I think sometimes we don't always appreciate it in transport, that all of this inflammatory milieu that's floating around in the bloodstream, we know it causes problems with other organs, for example, the brain. People become confused, say all sorts of weird things, and sometimes have decreased level of responsiveness, and that is septic encephalopathy. It's affecting the way that their brain works. It's essentially inflammation in the brain that's causing dysregulated brain function, and people are confused and kind of wonky and kind of out of it, and sometimes pretty darn somnolent. septic acute kidney injury. So it's not just a lack of blood flow. It's not just low blood pressure. And this goes for septic encephalopathy as well. People can have completely normal blood pressures, not be in shock, and have significant kidney injury just because of that inflammatory milieu and all those cytokines floating around, all those DAMPs and PAMPs that are floating around in the bloodstream, causing damage to the glomeruli and the tubules of the kidneys. And that is absolutely a thing as well. If you think about the cardiovascular system, you can get a septic cardiomyopathy, not terribly uncommon in patients to actually develop essentially decreased EF or problems with cardiac output that are not related to blood pressure itself, but actually dysfunction of the myocardium from all of this inflammatory stuff that's floating around in the bloodstream. Now, I say all that and talk about all those other organ problems and the inflammation and systemic inflammation causing these issues because this is absolutely germane to our obstetric critical care patients. Because if you think about it, these cytokines and all this systemic inflammation, if it can cause damage to the brain and the kidneys and the heart and the endothelium and cause problems with the clotting cascade, it can absolutely cause problems with another end organ, which is essentially, you can think of it as the placenta in the fetus. So it is absolutely an issue that we have to be aware of, especially as patients get sicker and they start to develop septic shock. So in terms of epidemiology of obstetric patients that actually get admitted, only about 5% of them that get admitted to the ICU are in septic shock. However, what's actually a little bit disturbing is some of the numbers. Globally, about 10.7 to 12.7% of maternal deaths globally are due to sepsis and septic shock. This means that actually sepsis has surpassed things like postpartum hemorrhage as of all the causes of obstetric critical care patients dying is number one. And that's a problem, and we have to be on the lookout. Now, I don't have any good data to support this, but my hypothesis, my belief, and my thought is actually a lot of this is because of several things. I mean, sometimes it's actually hard to differentiate what are vital signs and what are things that are the developing infection or the developing systemic inflammatory response compared to normal changes of pregnancy, right? Because we know that pregnant patients will actually have changes to their vital signs and that are normal, that could be consistent with the initial onset of sepsis or septic shock. So increased respiratory rate and heart rate and things like that. There are other things, which is why I think education about this topic is so important, which I think some of it is due to this concern, this fear, this stress, this anxiety about being very aggressive with obstetrical critical care patients in terms of treating the infection and managing their hemodynamics. And I think that problem is potentially solved by really good education, coordination, and collaboration with our OBGYN and especially our MFM colleagues that are very interested in taking care of these sick, critically ill patients. So in the obstetric population, are there certain things that put obstetric patients at higher risk of infection? Well, as it turns out, looking at the literature, there are. The associations are not always super strong, but some of the things on the list are things like obesity, immunosuppression. If a patient has lupus or some other condition, they're getting immunosuppressed, anemia, diabetes, and in particular, if that diabetes is continues to be uncontrolled throughout pregnancy. Other interventions, so cesarean section, so C-section, complex perineal repair of a perineal laceration, prolonged rupture of membranes, wound hematomas, and even things like cerclage. So for those of you who are unaware, a cerclage is essentially suture or surgical material that's tied around the cervix to prevent premature labor. But of course, anytime you leave something in there tied around the cervix, there is an association with increased infection under those circumstances. And then other chronic diseases, so chronic renal disease, chronic liver disease, any of those major organ problems lead to issues with the immune system where you're not functionally immunosuppressed, but your immune system's really not working exactly how it should and could be working better. And therefore, we do believe that that's the etiology of this association, why patients with renal disease and liver disease have additional or are more likely to experience infection. We're actually going to talk about that a little bit more, not just in obstetric patients in a different episode. So stay tuned for that. But we should be aware that in addition to the usual sources of infection that people get, this particular population has some increased risk or some specific infections that we should be aware of. So in the antepartum period, for example, things like septic abortion, chorioamnionitis, and especially other GU related pathologies and infections. So UTI, generally not cystitis. I mean, that can cause infectious symptoms, but generally doesn't progress to, in and of itself, doesn't cause septic shock, but absolutely if it becomes an ascending urinary tract infection, and absolutely if the kidneys become infected, if it becomes pyelonephritis, that can absolutely cause issues with, or that can absolutely cause septic shock. If you have infectious material in the kidneys where the blood actually runs through, and there is infectious material and some of that inflammatory stuff that causes that systemic or antigens that cause that systemic inflammatory reaction that are spilling into the bloodstream through the kidneys, then absolutely that can cause septic shock. And then other things that are similar to non-pregnant females. So, for example, pneumonia, appendicitis, that sort of stuff. Now, after delivery, that those more common organisms and sites of infection tend to change. So, for example, after delivery, things like endometritis, surgical site infections, perineal wound, so around the C-section, for example, or for a perineal wound infection. And again, UTIs specifically, and especially the ones that are causing septic shock, pyelonephritis, and pneumonia. Common organisms. We don't always worry about this too much in the critical care transport world, but it is probably a pretty good idea, I think, to have a reasonable understanding of like what the most common bugs are, because then when you look at the antibiotics, you understand why the ED or why the ICU is actually administering these antibiotics. And the most common organisms are E. coli, group A, B, strep, and staph. That's also important to know, I think, because especially when I see things like someone who's getting really sick and in shock, and they are growing out gram-positive cocci, and something comes back and it looks like group A strep, or there's anything in the medical record when I'm picking a patient up at an outside hospital that's talking about group A strep infection, man, those patients can get wicked sick really, really, really fast. So I am very cognizant when I see group A strep as a positive causative organism in any case, and especially in this population. Those patients get very, very sick very, very fast. So I would say, based upon that, we can move along and begin to think about this patient population and some of the things that I'm particularly worried about when it comes to pregnant patients. Well, first of all, obviously, there's two patients and not just one, right? So although if we get this right and aggressively manage these patients, they can have very, very good outcomes. Fetus can be okay, baby can be okay, mom can be okay. But mom does have, especially later on, closer to term, an impaired compensatory ability, right? The diaphragm is pushed up by a baby. So normally when younger, healthy females can compensate with an increased heart rate and increased respiratory rate, that's a little bit more difficult for pregnant females, especially as they get to term. And there's some other changes that are going on physiologically, like increased pulmonary capillary permeability that can cause issues like hypoxia and whatnot earlier or potentially before a otherwise younger, healthy, non-pregnant female. I think the most important thing that I want to get across to people, and I tell people in the ICU this, I tell my emergency department colleagues this, and I absolutely stress it with our critical care transport crews. This is a different patient population, but they are not aliens. The general treatment scheme for pregnant patients is very similar, with maybe a few changes as it is to any other septic patient you treat day in and day out. So relax. Take a deep breath. I know it's really stressful when you have a patient that's 36, 37 weeks pregnant and now in septic shock. That can be very intimidating. But know that by and large, you do exactly the same stuff as you do for other patients with maybe a couple of other considerations. You guys know how to do that. You do that every day. We see it every day in the emergency department and the ICU. So don't be intimidated. Get on it and do the normal stuff that you would do to aggressively resuscitate these patients. All right. And that said, let's talk about how you're going to do that. Well, antibiotics. And again, for most of our critical care transport crews, there are many flight services out there that don't necessarily carry antibiotics. I'm going to go through a couple things because I think our crews are generally smart enough to know and kind of understand the general schemes and the general antibiotics that we give people, and especially our physicians and associate providers, or our advanced practice providers, our PAs and NPs that are flying should definitely know this. So of the things that tend to cause infection, some of the regimens that you might see or should be aware of are, for example, for pneumonia and for severe community-acquired pneumonia, in particular, ceftriaxone and azithromycin, or upping the ante and going to Zosyn plus azithromycin plus or minus vancomycin. For chorio, endometritis, UTIs, Amp-Gent is absolutely a reasonable combination in this particular population, plus or minus clindamycin. For anything intra-abdominal, generally speaking, across the population, ceftriaxone and metronidazole would be a reasonable cocktail to cover just about anything that's going on in the belly, or you could just use Zosyn as a single agent would be reasonable. For soft tissue infections or necrotizing soft tissue infections in particular, Zosyn and vancomycin is a very good place to start empirically. A lot of these infections are actually polymicrobial. If they're getting really sick, they look like they're in toxic shock, I would add the clindamycin to cover for group A strep, toxin suppression, as well as clostridial infection, which would be really rare, but is absolutely possible. And I think there's very little downside to adding it at that point. So those are some common regimens. I think the most important thing for our flight crews that don't necessarily prescribe antibiotics, if you can take one thing away, make sure that they have antibiotics on board, make sure they have antibiotics on board, make sure they have antibiotics on board. This is in all the guidelines. There's very clear evidence. Sometimes we have heard it reported where patients they're literally getting shuffled out the door. Critical access emergency departments are so concerned that they are in the heat of the moment and trying to get patients transferred out the door and to the receiving facility. They don't get their antibiotics, or they're delayed coming from pharmacy, or they're just dripping them in for a non-septic or non-septic shock patient, and then infusion is going over like some ridiculous period of time, like hours. I think the most important thing is to just look at the patient, look at the medical record, and talk to the sending facility and be like, have they had at least some reasonable broad spectrum antibiotic coverage, yes or no? I don't think you necessarily need to get down to the weeds on this, but as long as there's at least some broad spectrum coverage on board before you get going, timing is so important for that. I would say most places seem to get it done and understand that at this point and will get it done quickly, but double check, make sure that they have antibiotics on board. Fluid. Generally speaking, looking across the literature, and most of the guidelines suggest that it's probably reasonable to go with an initial fluid bolus that is somewhere in the realm of what the Surviving Sepsis Campaign recommends, in like the 20 to 30 cc per kilogram range. I would add to that the caveat that if you're a critical care transport team with the appropriate experience, you have training in ultrasound, it's also very appropriate to use dynamic tests of fluid responsiveness. Again, this is all as long as it's not really holding up transport, and test to see if they're actually fluid responsive. There is no good data, but I also don't think that in thinking about a obstetric critical care patient, that we should also be hammering them with fluid that is excessive, especially if they're not responding to it. Why? Well, again, they have increased pulmonary capillary permeability. We know that, for example, during labor, airways tend to swell. There's lots of fluid retention, and some of that is essentially from a survival standpoint, natural physiologic changes, maternal physiologic changes. But giving way too much fluid just because someone's a young female is also probably not great. So again, like any other patient, starting out at a reasonable 20 to 30 cc's per kilo, but taking into consideration that they may need earlier than normal pressors or other agents. So dynamic tests of fluid responsiveness are appropriate, looking at their heart and or looking at other things like passive leg raise to see if that is actually, if they actually need additional fluid or it's time to add pressors. So moving right along, while we're on the topic of pressors, early norepinephrine is probably pretty reasonable too. And in general, it's safe for the fetus. I really want to point this out because I can't tell you, I've heard this in the emergency department. I've heard this from ICU providers. I've heard this when I received patients in transport. Well, I was really worried. So I didn't start the norepinephrine because I was afraid it was going to constrict blood flow to the uterus. We have reasonable data at this point that it is safe and okay to administer pressors. Yes, there are some studies, especially studies from like the 70s, 80s, and into the 90s, and there's a couple actually in between 2010 and 2020 or so that look at animal models, and there is data that's collected that basically shows that pressors can decrease blood flow to the uterus. But a couple things: one, they're almost always in animal models. Two, and this is probably the thing that stands out the most to me, if you look at what they did in some of these experiments, they're mainly hemodynamic experiments that look at changes in blood flow to, say, the liver and the gut and the uterus and the intra-abdominal organs and what happens in different blood vessels. But I think what pertains most to us is the fact that in order to do these physiological experiments, they were giving patients really high doses of norepinephrine, and it is arguable whether that decrease in blood flow was actually of clinical significance. I think any decrease in blood flow may be of clinical significance, but there was no data on that. But the main point that I want people to take away is in any of those experiments that show decreased blood flow to the uterus, they were using like 1 mic per kilo per minute. So, for example, there's a couple papers that did it in pregnant ewes, female sheep that were essentially like in the 40 to 46 kilogram range, and they gave them 40 mics a minute. So that would be like the average pregnant female giving her 70, 80, 90 plus micrograms per minute of norepinephrine. We really clinically in practice don't do that. Right? Even if you add on, even if you get like 20 or 30, or the equivalent of 0.2 or 0.3 mics per kilo per minute of norepinephrine, which is, I would say, the higher end of what most ICUs are doing and most transport crews will do, up to, like 0.4, 0.5 at the higher end of what I've seen in clinical practice. And you're adding on vasopressin, we're really not getting to the levels that we're seeing in these studies of like 1.0 micrograms per kilogram per minute. That's a lot of norepinephrine. Either way, across the literature and across the guidelines, the risk of some potential decreased blood flow versus overall making sure mom's map is okay, that all of the organs are getting perfused, and that we are maintaining hemodynamics. The benefit of all of that outweighs any hypothetical risk, and we should be giving these patients pressors if they're indicated, starting out with norepinephrine, and several statements and guidelines from some of our MFN colleagues also endorse this, as well as going sort of in tow with the Surviving Sepsis campaign guidelines. If you have to add a second vasopressor, vasopressin would be up next. Interestingly, steroids are safe and reasonable. So some of the MFM literature in the obstetric critical care literature, although, again, there's not great data for this. In fact, there's very poor data. We don't study this or randomize pregnant patients to some of this stuff at all. Would say that kind of what we usually do for patients would be appropriate as steroids is concerned too. So about 200 to 300 milligrams of hydrocortisone a day. In other words, a dose of 100 milligrams of hydrocortisone or 50 milligrams of hydrocortisone, or as we often say in the ICU, starting stress dose steroids is absolutely appropriate. If they're really hemodynamically compromised and in septic shock, I also think if you have the training and you have the time, and especially if you really can't get consistent blood pressure cuff readings, it's very reasonable if you're a trained crew to place an arterial line before transport. So you can monitor that very closely. You can titrate your pressors appropriately. If you're going to be drawing, especially point of care labs, if it's a long fixed wing transport, for example, and you're going to be gone or traveling on the road or in the aircraft for 2 or 3 hours, and getting point of care blood gases and point of care lactates and other labs along the way, totally reasonable because you can draw those gases right off the arterial line. I would never hold up a procedure if there is a surgical. I would never hold up transport for a procedure like that. If it was a surgical emergency, absolutely get to the sending facility, and you can consider doing it on the way. But it would be an appropriate intervention to consider. These are definitely patients where I would very closely monitor the fetus. And if there is a particular patient population, patients who are hemodynamically compromised, I will definitely work hard to make sure that the tachometry is in place, that we're getting as best a reading as possible, and really watch that carefully. Again, remember that if you consider the fetus as sort of an end organ, that physiologic milieu, all that inflammatory stuff that's floating around the blood and going to the placenta, and that dysregulated cytokine activity can absolutely and potentially cause premature labor, and can absolutely cause changes to fetal blood flow and changes to the placenta. So I would absolutely watch the fetus and consider it like I was getting labs on a kidney, or I was echoing the heart to see if there are any problems, and watching hemodynamics and monitoring, and essentially, like I said, an end organ, I would be continually watching the tachometry, fetal heart rate, etc. So lastly, one of the more, I shouldn't say more common things, but one of the things that definitely comes up in the setting of sepsis is compromised pulmonary function, especially given the fact that you have this giant fetus that's pushing up on the diaphragm. The diaphragm has flattened out, that it is going to be more difficult for patients to compensate from a respiratory standpoint. And if you look at compromise or changes to pulmonary vascular permeability, it is that can certainly compromise things, or it can certainly add to issues as it relates to pulmonary compensation. And so consideration for intubation and mechanical ventilation should be considered. We are going to hear pretty shortly, hopefully, we're going to be doing an episode on airway management in the obstetric critical care patient, as well as we have done, and I posted the episode on ARDS and mechanical ventilation for other non-ARDS obstetric critical care patients previously. So check out that episode for more information. So the take-home points that I want to really make here are, number one, sepsis is now the number one reason that pregnant females die, and we have to be on top of this. There are some unique sources of infection or sites of infection in pregnant patients that we have to be aware of. Things like chorioamnionitis, increased risk of urinary tract infection after a patient's delivered, endometritis or surgical site infections that we have to be aware of. On physical exam, we should be taking a look at. And in terms of management, I think the pearl that I want to get across to people more than anything else is there's no crazy changes that should be made. By and large, the management of obstetric critical care patients that are in septic shock in particular should be as you manage any other super sick septic shock patient. Make sure they got their antibiotics as soon as possible within the first hour, especially if they're in septic shock. Fluid resuscitation starting out with 20 to 30 cc's per kilo is totally reasonable, but as we get closer to the 20 to 30 cc's per mark, it's also very reasonable to think about doing dynamic tests to see if these patients, just like any other patients, are fluid responsive. Norepinephrine is safe, it is reasonable, and it is recommended in the MFM and OBGYN literature as a first go. And when I say safe, remember, it's actually been tested for patients who are hypotensive, who have had epidurals and other things, and they looked at it and it's been just as safe as other medications like phenylephrine. So please, 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 it is safe and reasonable. Don't be scared to start pressors if they're hemodynamically compromised. Chasing that up with vasopressin as a second line pressor, considering stress dose steroids, arterial line if you have the time and if it's reasonable and if you're appropriately trained, and then absolutely continuous fetal monitoring for these patients if at all possible in transport, and then watch out for other complications, specifically respiratory complications and things like ARDS in this patient population. Thank you guys very much. Stay safe out there, fly safe, and we will see you for the next episode. Take care. Bye-bye.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.